And we're marching on into spring with the Fab Four, who is joining us here tonight. And glad you're with us on Health Watch Oklahoma with the Fab Four, which is minus one member tonight. Dr. Sublet's not going to be with us this evening, but we'll see him next time. And of course, it's the Fab Three: Dr. Dale Bratzler, Dr. John Armitage, Dr. Larry Blickman. Good to see you all. I have a little bit of a calendar note to make, which is just marched into year 3 of Health Watch Oklahoma, Dr. Blickman.
3 years. Believe me, I understand. It's actually been 4 years since we started. We started when I was president of the State Medical Association in 2018. Different name, but same program. So we've been on a lot.
We have, and we were shooting it with an iPhone in the beginning.
That's right.
We're significantly more teched up now at this particular time, so it's great to know. One other programming note: since we began this program, which used to be on Monday nights, started out well before Monday nights, and then Monday now moved to Wednesday every other week with Dr. Blickman. Now we have the Education Watch Oklahoma on Saturday morning, and 10 o'clock Saturday we'll be on Talking Aviation and Education. We got some great guests lined up for that, and of course Monday night. Last night we were on instead of Monday because of some weather-related issues, but glad you're here. And a quick announcement, we've got a lot of people wanting to ask questions tonight. At the bottom of the hour, we'll take some of those questions. In the meantime, Dr. Blickman, Dr. Bratzler, Dr. Armitage have a great show lined up. Dr. Blickman, take it away.
Thank you, Scott, and thank you to all the listeners. We always appreciate all the listeners every week, now once a month for the panel. So welcome to Dr. Bratzler and Dr. Armitage, and thank you for being on. I want to start off with what everybody is talking about, what everybody's worried about, and the news every night now talking about, and that is the spread of the Omicron subvariant BA2. We've seen in Europe that 18 countries now are showing increase. People are getting worried. Dr. Bratzler, what does BA2 mean to this country? What do we need to look for?
Well, so we know BA.2, or the subvariant or stealth Omicron, is in the United States. In fact, about 23 to 24% of all the new cases that are currently diagnosed in the United States are due to that subvariant. In this particular region of the country, which is called Region 6, which includes Oklahoma, about 18% of the new cases that are being diagnosed are due to that particular subvariant. It's very contagious. It seems to spread even easier than the original Omicron variant, but it doesn't appear to be any more virulent. In other words, the disease that happens doesn't appear to be any worse than it was with Omicron. Good news, if you're vaccinated, the vaccines seem to hold up reasonably well against this particular subvariant. Certainly helps to keep you out of the hospital and have severe complications. And if you were infected with the Omicron variant during that huge peak that we had in December and January, that also seems to give you pretty good protection.
One of the things that we've seen, and in Europe, they're increasing some of their restrictions again because of the peaks that they're having. And the mask mandate in this country by federal guidelines was increased to last until at least April 18th, another month. Are we looking forward to seeing other restrictions, more mask mandates? We're seeing the country open up again. Do we see that reversing, and do people need to worry?
I'll start. At this moment, I don't see us going backwards unless we see the case counts start to rise again. So despite the fact that almost a quarter of all the new cases are due to this new variant, it simply hasn't, at least in the United States, increased our case counts or our hospitalizations. They continue to fall. They continue to fall in Oklahoma. So I don't see us going backwards unless we see a rise in cases like they're seeing in Europe.
And I think, from my perspective, the momentum we're going to need to reverse is probably the most we've ever had, because the airline CEOs are asking for relief from masks. People who in the past would have been strongly advocating for their employees' safety and for measures, they're now on the other side. Some of the politicians, I think, are realizing that this might not be a vote winner if they stay on the mask too long. So again, I think the momentum is now, the headwinds are stronger than they've ever been for us to go back and do this. Not that we won't, if, as Dr. Bratzler points out, we start seeing ICUs fill up and, mortality go up, and, but I think it's going to take a big push now, maybe much bigger than previously.
One of the concerns I have is that we're seeing and have been seeing a trend of decreasing testing, marked decrease in vaccination rates. I'm not sure how we reverse that. As Dr. Bratzler said, the vaccinations are very effective against this subvariant, yet people aren't really getting vaccinated. And a real concern is that we have this armamentarium of drugs that we can use to treat COVID. And John, as you and I talked about, we're seeing a very slow, I'll put, response, a very anemic response to using any of these drugs. Less than half of the supply of Paxlovid and I could say it's Sotrovimab have been used, and less than a quarter of the Evusheld has been used. What do we think's going on? I mean, this is even our doctors not using the medications.
Well, I'll jump in to say I think this is part of endemic. Our country struggles with a lot of public health measures, whether it's flu vaccines or other, weight loss, blood pressure control. There's a whole host of things that we get into a chronic under acceptance of good practice. I think what you're seeing is the mentality is falling into that endemic. The folks who don't engage in other health behaviors probably aren't going to engage much with therapies if they think they can ride it out, which I think the signal is now that the risks are fortunately lower with Omicron than they were with maybe Delta and the first go round. So I think what we're seeing is a shift in mentality to baseline, which is not a great baseline for us. And I think that's a challenge. Maybe Omicron, we stay after this a little bit more aggressively and learn some of the communication tools and the things that vex public health chronically. They vex COVID response in the endemic phase. So let's work on them. That's a 2-cent opinion.
Dr. Bratzler?
Yeah, so first on vaccines, I think the people that really wanted to get vaccinated have been vaccinated. Many of them got their booster doses. And I think there are quite a few. I've talked to a number of people that are waiting for the second booster dose. They want to make sure that they're going to be protected going forward. I think it's likely, you've probably heard the news from Moderna. It looks like their vaccine may be pretty effective in kids under the age of 5. And that will be another group of people who, even though most kids, when they get this infection, don't get really sick, a few do, but not everybody, and many of them don't, but they can spread the disease. And we've seen that with other respiratory viruses. If you vaccinate children, you see fewer adult cases. So I think, we'll see spurts of vaccination. Certainly if we see an uptick in cases, I think we'll see it. I'm particularly interested in the conversation about the drugs that we have to treat COVID-19 now. We're in a very different spot than we were a year ago because we have 2 antiviral medications. We have 2 monoclonal antibodies that are now approved that have been shown to reduce hospitalizations and death in people who have COVID-19. Of course, convalescent plasma in the outpatient setting could be used, and also remdesivir, one of our IV antivirals that we've been using for a long time. maybe not as effective in the hospital setting, but seems to be pretty effective, about 50% effective in the outpatient setting before people are sick enough to go in the hospital to keep them out. Sometimes doctors don't think about this. And I think it's really important that we keep educating the public that if you test positive and you have symptoms, and you particularly if you're older or if you have chronic illness, please seek out these medications because they have been shown to be very effective at preventing the things that we care about the most, which is hospitalization, complications, and death.
I think that's the most important point that I wanted to have brought up, is that the people need to educate because sometimes our physicians just aren't thinking about it. And so, it's easier to look after yourself and maybe suggest that to your physician. But you bring up a very important point, and that is the boosters. We've seen only about 40% of our adults get boosted in this country. I think the latest number was 48%. 60+% of over 65, which is where I fall, have been boosted. So the seniors have really taken it seriously. But now we're talking about a fourth booster. Both Moderna and Pfizer have requested that. What do we think? Do we think Moderna asked for all adults? Pfizer only asked for those greater than 65. Dr. Bratzler, I'll start with you. What do you think about boosters at this point? Do you think everybody should be getting it, or just those in the older age group?
So if you look at the literature, the studies that are out there, it's actually a second booster, if you will. It's the two primary series, and then those people that have had that first booster are getting a second one. And I think it may be reasonable for the elderly or people who are immunocompromised or people who have underlying illness that would put them at risk for the complications of COVID-19. But a big study that just came out of Israel, where they gave that second booster dose to healthcare workers, actually showed that it didn't seem to make that much difference in that younger and healthier population. So one thing that we are learning is that if you're fully vaccinated and you've had your booster, you're pretty well protected against the bad things, hospitalization, complications, and death. You may get COVID. We saw that through Omicron substantially. A lot of people who were fully vaccinated got COVID-19, but very few of those people ended up in the hospital. I think that's the really important point. So I think we will be giving additional boosters, particularly to those that are at highest risk of the complications.
Yeah, and I think one of the opportunities again here for us to work on public education and invite people into kind of the inside baseball of some of the public health measures we're attempting. I'd like to see what the benchmarks are versus flu vaccines. We're talking about similar kind of high risk populations where we really want the vaccines every year on the flu. What is the baseline? What's the target that we know is achievable with a pretty well established therapeutic approach, preventative approach? Let's get that out in front and say, we should be paralleling or beating our previous behaviors. I mean, if anything, I would expect we should hope that we get better at flu and we get, higher numbers, therefore, with what might have otherwise been our COVID vaccinations and boosters, because we've been through a trauma that should educate us to be more diligent. So again, but those numbers need to become kind of front and center. That needs to be the new target. I mean, unfortunately, when we started this, we were talking about herd immunity and 70 or 80% of the population, and we dropped that. That went completely away from the discussions. I mean, it may be still active in some specialty areas where, but the public's certainly not focused on it. And I think we're going to run into the same problem with vaccines. If we don't put a target and an expectation and a kind of a team effort behind keeping the numbers up, they're going to go lower than they would otherwise. And, that's on us. So
Yeah, I think probably flu may not be a great benchmark. I don't know if you saw the literature that came out recently that this year's flu vaccine missed the target, and very poor response. So
how
probably
about
not
flu
the
in a good
best.
year?
Yeah, flu in a good year. The Israeli study was interesting to me in that they showed that 4 months after they gave a fourth shot, 4 months after the third shot, and they only showed a 1 or 2 time increase in their antibody response, infection rate. So it was pretty minimal, but they still are recommending it. And of course, a lot of people here are talking about a fourth shot. And that brings up, is the 6 months that this booster seems to be effective going to continue? Or are we going to see with a fourth booster such a response that it may last a year or two? Because I think people are going to get tired of being boosted every 6 months. So, we go from fourth to fifth to sixth. I don't think that's going to fly.
And I think we need to, when you look at most of these studies looking at boosters that are looking at antibody levels, I think we need to get away from that. We need to focus on the outcomes that we care about the most, which are hospitalization, complications, death. Again, even though the flu shot wasn't great this year, it still kept a lot of people out of the hospital. People got the flu that had the flu shot. That happens every year, but it keeps them out of the hospital. When you look at the studies of the Johnson & Johnson vaccine, we all acknowledge that it wasn't nearly as effective at preventing disease as the RNA vaccines, Pfizer and Moderna. And yet those people still have relatively good protection against being hospitalized or having complications of COVID-19. So remember, there's a second part of the immune system that we don't talk about often enough. That is our memory immune system. And it appears to work. You may get COVID, but you don't end up in the hospital. So I'm like you. I don't think we're going to need to have every 6-month boosters or anything else. I do think that, I'll be one of those people that's a candidate for a second booster dose, a fourth dose. I may want to wait until the fall, since I think there's a good chance that COVID may follow some of the same patterns that influenza does and become more of a seasonal virus that increases in the fall and winter months because it's a respiratory virus.
And I would say one of the journeys perhaps we will start taking around boosters is some more transparency or more visibility on the correlation between neutralizing antibody assays and protection. I mean, to be 2 years in and to have so little commonly useful knowledge around that aspect of immune monitoring and boosting. It's surprising to me, and that seems like a direction that would help everybody get a firmer commitment when they are below a threshold that seems to be risk for their age group, or however we define those thresholds. But to me, that's a missing part of this equation: is where's the testing that we can correlate the vaccination to some level of protection?
Yeah, I do think that Dr. Bratzler hit it on the head that what we really need to be focusing on, and I wish our public news media would focus on, is really hospitalizations, not just the number of positive tests, because people who test positive and aren't symptomatic has no meaning. What we really need to know is, are we having increased hospitalizations? Are people getting really sick, dying? And again, better testing, better assays, understanding the disease process a little better, and getting the politics out of it. And that leads right into my next subject, which is the politics and the spread of misinformation. And we know our politicians from the top on down have spread misinformation. But now we're seeing physicians partly because of social media. You know, in the old days, a doctor could say something wrong and nobody heard it but the patient that he was talking to. But now with social media, we're seeing tremendous response to disinformation from physicians. Simone Gold, who's the founder of America's Frontline Doctors, and John, you and I watched as they were in front of the Capitol talking about ivermectin and how vaccines, nobody should get vaccinated. What do we think about what's going on with physicians, and specifically not only what's going on, but the lack of medical boards, state boards having any action? Shouldn't they be doing something to protect the public? John, I told you I'd start with you on this one.
You're asking for trouble. Well, we had an earlier conversation about this. I think physicians aren't modeling the best behavior themselves in a crisis of information, which I think COVID could be characterized as. The fact that there are people willing to stretch beyond their area of expertise to make go beyond opinions to position themselves as expert opinions. I mean, everybody's entitled to an opinion, that's free speech, but to posit that you're an expert, you need some credential. I think in medicine, that's pretty well established that you don't want to hear from your clinical pathologist friend, Dr. Armitage, about your surgery procedure in too much detail. And thankfully, I was trained not to get too deep into that because it's not my area of expertise. But somehow when we get on the media or we get on social media, a lot of that discipline seems to erode down to the common level that the regular internet transactions are, where you don't have to have credentials and you don't have to have expertise. And if you think you've got even a slight hint of a background in a subject, you're entitled to speak about it. I would hope that the physicians could start modeling, don't talk about immunology if you don't have an immunology background, some serious chops when it comes to your level of expertise. If it's not on your resume, don't put it on your social media. But we've lost that in medicine. I think we should put standards out there. What is good? What are the behaviors that we as physicians should be modeling in terms of the credibility that we want to establish? We're credible because in the past we were experts when we made it to the microphone. Now we can make it to the microphone whenever we want, and we've lost the ability to maintain the expertise, the boundaries, the ring fencing. John, don't talk about surgery. John, don't talk about nephrology. But John, talk about testing and talk about home testing later, maybe. But
yeah, the social media seems to have created a lot of this. And Dr. Bratzler, I mean, even the political side of it, in Florida, they named a surgeon general who promotes ivermectin. I mean, I'm not sure where we go. A complaint was filed against him, and the state of Florida did nothing, saying that he hadn't broken any laws. Well, he broke the law of medicine.
Yeah, but I think, so I want to highlight, it's not just physicians. I think physicians are there are physicians who are just as susceptible to the pressures of social media as other people. And I've been in direct conversations with PhDs, some with no relation to human health care, who have argued strongly that they're experts in the field and have made what I consider to be very ludicrous recommendations. As you know, in our state, the Attorney General has said that he can find nothing that prevents a doctor in the state from prescribing ivermectin if they want to for COVID-19. And many states have muted their medical boards to prevent them from taking action against physicians for disinformation that's out there. I guess where I come down on this is doctor beware, because just because the medical board doesn't take some action or doesn't make recommendations, you're still medically liable for the care that you give. And the patients, and there are patients, I believe, who have done poorly because of misinformation, misprescribing, and other things that I think put many physicians and others at some legal risk. We have national guidelines that explicitly recommend against the use of a drug like ivermectin to treat COVID-19. I strongly support trying it in clinical trials, but right now there just aren't the clinical trials showing the impact or the effectiveness. So doctors do put themselves at some risk when they do those things.
There was a very good article that talked about this. Both Florida and Tennessee have such laws, as the Attorney General in Oklahoma has talked about, where physicians are allowed to prescribe and they don't have a problem or see a problem with that. But one of the authors of an article brought up a very good point, that if a physician tells a patient, you don't have cancer, but they actually do have cancer, that doctor has performed malpractice. So if a doctor prescribes for COVID something that is known to not be effective, is that not bordering on a malpractice? And, I think that our state board of medical examiners needs to be able to weigh in on that. I don't think we should handcuff them. And freedom of the press and freedom of speech don't qualify when it comes to professional language. When a doctor says something, there's a difference than just freedom of speech. John?
Yeah, I think one of the disciplines when we're looking at the behaviors that this has exacerbated, if you look at off-label use of drugs, we've allowed ourselves quite a lot of flexibility traditionally. And now when this moment comes where the stakes are maybe a bit higher, or maybe not, they're not higher, but they're more widely viewed, they're more obvious. We don't have the structures in place as to what is appropriate off-label use, in a rigorous kind of commonly accepted framework. That's my, so we sort of let the horse out. A couple of other horses are down in the pasture already. And then when this horse goes down there, we get really upset, but it probably gets back to how we've maintained the barn door in the first place. And we need to own that and maybe work on that. As much as we want to discipline people in their free speech or their medical liability, there's also a huge framework of, what's acceptable off-label use. How far can you go with that? What are the parameters? And they're very flexible as far as, I don't do a lot of prescribing, fortunately, in my current position, but as I recall, you can do a lot under that framework, and maybe we need to review that and put some muscle behind it.
Larry, just recently, I review a lot of charts at OU, and we saw a patient who was transferred to us with severe COVID, was already on a ventilator, and was transferred to our medical center for care. And when we reviewed the records, what we found was the patient had been treated with a host of things for which there are good clinical trials that show that they don't work to improve the outcomes from COVID. They'd received antibiotics, which don't work. That's a virus. They'd received a variety of vitamins. Sounds great, but they haven't ever been shown to change the course of COVID. And had received ivermectin, which there are national guidelines that explicitly recommend. And, I could live with all of that if that patient had been offered monoclonal antibodies or antiviral medications, or something for which there are very good randomized controlled trials that show that they work. They reduce hospitalization and death. But this patient was not afforded that opportunity and subsequently passed away from COVID-19. So that's where I get really, if somebody wants to try something off label, let's face it, in much of healthcare, we don't have really good, strong randomized trials for many things that happen in healthcare. But when there are drugs for which we do at least offer those to the patient so that they at least have had the opportunity to take the drugs that have been clearly shown now to improve the outcomes from the disease.
And as we said, we have good drugs that aren't being used, and yet then we hear cases like this of drugs that probably are not effective. Nothing has shown they are effective, and they get used. I brought up last month a study that came out that Oklahoma was in the top, I believe, 5 states in using some of the monoclonal antibodies that are no longer effective against Omicron, and yet they're still being used. And you wonder, is this political? Is this just lack of knowledge? I'm not sure. I don't want to say the doctors are doing things that they know are wrong, but I don't know why that doctors who are treating COVID patients aren't necessarily keeping up and using the most effective treatments. John, you're chomping at the bit.
Well, I would just like to point out that the government is hugely complicit in the confusion around monoclonals. They should have taken those monoclonals that didn't fight Omicron out of circulation immediately. They attempted that. The pushback was too strong politically for them, and they reintroduced the distribution of those monoclonals. And no wonder people are confused. You told me it wasn't worth anything, and then you turned it back on and gave it to me for 5 weeks until a better monoclonal was more readily available. That doesn't excuse the physician of keeping up with it, but I would say in this category, disinformation got a huge assist from the way that drug was handled at the regulatory level. And one other thing I'd love to follow up on what Dale said about if you've got a good physician, if your personal physician is worth his salt or her salt, then they're going to give you choices. They're going to have a conversation about what your therapeutic options are. And it's the whole range of therapeutic options should be as part of the discussion with recommendations or for or against or whatever it is. But the people who get vitamins and aren't offered several other modalities at the same time, these therapies are often not using the same mechanism, so they can be additive potentially. But you end up in these cul-de-sacs of kind of single thinking of a physician's preference, and it doesn't engage the patient. So the patient, I think anybody listening should expect their doctor to give them a range of therapeutic choices with some expertise behind each one of those choices. If you ask, pros and cons, and then the physicians, should be doing the service back to their patients. And I know time often weighs against that. People are very busy. But again, we're only going to get to good medicine if we stop letting the clock dictate some of the practices that we have to do well. Lives are at stake. Poor therapeutic options, poor education of the patient in this case leads to a death that Dr. Bratzler described. So again, I would just encourage the physicians to lay out the menu, lay out the buffet, and that the patients have to take some ownership of expecting that and then interacting with their physician and not just tell me what to do. You're encouraging cul-de-sac thinking.
Well, I agree. And I often think that patients sometimes have a gut feeling that maybe they're not going the right way. And I've always recommended to my patients and any patient that if they have any questions, get a second opinion.
Absolutely.
No doctor should ever resist a second opinion. And I think that would solve a lot of issues
Completely agree with you, Larry. I encourage it. It made me feel good when patients want to get. I mean, because I might learn something, or that patient may come back to me feeling much more confident when they had another opinion. So I strongly always encouraged second opinions. I do want to give doctors one break here. I have a slide that I update about, and when I give a COVID talk, that I update periodically. Since early 2020, there have been somewhere around 280. We're probably approaching 300,000 articles published now on COVID-19. And it's true of all fields in medicine. So, Larry, you're a GI doctor. There is no way you could read all of the literature that comes out in your field. There is no way that John can read out all the literature that comes out in his field, nor can I in my field. No doctor can keep up with all of the literature. So it's one of the challenges that we do have in healthcare now, is that there is so much literature out there that it is hard for doctors to keep up with the most recent recommendations. And that's why I think it is important that you think about what your options are. And then I think your idea of your recommendation that, if you're concerned, get another opinion, which I think is really important.
But not off the internet. Get an expert opinion.
Good point. Good point. Well, I know Dr. Sublet's not here tonight, and that's unfortunate, because there's been some new things in the pediatric part of COVID. Dr. Brassler, I believe, brought it up earlier that Moderna has announced that they're going to seek EUA for 6 months and older. I think that's great. We've got boosters for kids. Pfizer now has Paxlovid, which for 6 and older children. And it was recently announced that 35 different companies worldwide have applied, offered, put their names in the ring to produce generics of Paxlovid and be able to supply those to the less fortunate countries. What do we think about the kids today? And let's talk also not only about the medicines they can get and the vaccinations, but also masks in the school, because there's been some studies on that. Dr. Brassler, I know you're not a pediatrician.
Yeah.
We're going to try to move on without Dr. Sublet here, but what's your opinion on any of that?
Well, so a couple of things. There have been multiple studies now looking at school districts with mask policies, and the data there's so many studies now that show that school districts that had mask policies had lower rates of COVID infections. Now, remember, most kids don't get seriously ill, and it's difficult to evaluate the downstream impact on mortality, hospitalizations, because it is often the parents, the caregivers, or others who may get sick when that kid gets sick at school. But the studies are just repeated over and over, multiple states, showing that the counties or school districts that had mask mandates had fewer cases of COVID in their school. So I strongly encouraged it. I mean, right now our case counts are very, very low, but certainly if we see a surge, I think it's an important way to slow the spread of the disease. Vaccination, of course, I know many parents, many of the pediatricians I do work with are very excited about the possibility of having a vaccine for kids that are 6 months of age and over. We've been doing the same thing for influenza for kids for a long time. Studies out of Japan a long time ago showed that if you had policies of vaccination of children, you saw far fewer adult cases of the disease. So I look forward to having the availability of the vaccine for kids. And again, we're using the same vaccines today that we started with in December of 2020, the same ones. Nothing's changed. The formulation is no different for Pfizer and Moderna in particular. It's the exact same vaccine, just comes with a different label now that they have FDA approval, particularly for Pfizer's. So remarkably safe, clean vaccines, no preservatives, no heavy metals, all the stuff that we've heard about, complaints about with kids' vaccines for a long time, don't have any of that stuff. They're incredibly safe vaccines. And so still strongly support vaccination policies.
Yeah, I've got 3 grandchildren, all under the age of 4, and I know my daughters are looking forward to when vaccines can be approved for that age group, the 6 months and older, to get their children vaccinated. It's interesting to me that in the United States, we've not approved Moderna yet for that young, but in Canada, children are approved for the Moderna vaccine, and they've seen no problems with it. So hopefully Moderna will get approval fairly soon and be able to have Moderna or Pfizer vaccines available for our children. Studies have definitely shown that the vaccine is effective, even in kids. And yes, kids don't get as sick, but the loss of one child is one child too many. So, we need to get them vaccinated. Yeah, go ahead.
It's kind of interesting to me that the paradigm of this acute pandemic and the fact that the adults were clearly at higher risk and they got the vaccines first, and regulatorily that made sense. But the regular paradigm for vaccinations is in infancy. So, it's kind of funny that we're fighting about should we do young folks with vaccinations when that's where most of our vaccinations take place. So, hopefully some of that logic starts to seep in once we get into the endemic and out of this acute kind of paradigm. So maybe there's some hope there.
I never have understood the arguments that people are making about the vaccines and the quote mandates, although we don't use that word anymore either. But when my kids grew up, when I was a child, vaccines were required for certain things before you could go to school. This is just another vaccine. And as Dr. Brassler pointed out, a very safe, clean vaccine. So I don't understand why there's so much resistance to this one vaccine when there hasn't been to all these others over all these years. I don't know. Again, I believe politics plays a big part in that, and that's what we need to get out of medicine. Medicine needs to be medicine. Politics needs to stay in their lane. So we've got about 15 minutes, and I wanted to leave enough time. Scott, are you there? Do you have any questions?
Got about 3 good ones here from viewers that came in on my email. Here's one comment. The lack of media coverage of the study about the folly of ivermectin shows medical boards and media both lack courage. That's an interesting one. All right, here's the first one. This person says, I've lost count. It seems the media no longer regularly reports on boosters. How many shots should wise people have had by now?
3.
So it depends on your underlying condition. Let's say you're a healthy or otherwise healthy 65-year-old that's getting vaccinated. You need to get the priming series, which is 2 doses, Pfizer 21 days apart, Moderna 28 days apart. That's the priming series. And then 6 months, they changed it to 5 months. 5 months after that second dose, you get a third dose, which is your first booster. So for most people, myself included, 3 doses. That's how many I've gotten, and that's what's recommended for people. If you happen to be immunocompromised, you're truly immunocompromised, you're cancer chemotherapy, you're on drugs for rheumatoid arthritis or other immunocompromising conditions, we recommend that the priming series be 3 doses. So you get your first 2 doses And then 1 month after the second dose, you get a third dose. And then you get your booster dose after that third dose. So you up to 4 doses. So immunocompromised people, we already recommend 4 doses for.
And you might explain before you go on what immunocompromised means. They don't get the same response, and that's why we're recommending that.
Yeah, so there have been multiple studies that show that people who are immunocompromised, you're on a drug like a monoclonal antibody to treat rheumatoid arthritis or cancer chemotherapy, your immune system just cannot respond as well. And so we do recommend that the priming series be a series of 3 doses of the vaccine. And then you get the 4th dose, which is your first booster down the road. So again, 4 doses is the most that's recommended currently for anybody.
All right, and one more that's kind of off brand here, but it's interesting. This lady says, I called my eye doctor today for a copy of my prescription. I asked them to send it to me. They said they couldn't because I have glaucoma. I went there for a refraction, not a glaucoma screening, but they always ask me for my insurance card. They probably billed my health insurance. So could this be insurance fraud? And P.S., my eye doctor is not an MD. What should I do?
Well,
I'll leave Dr.
yeah,
Brassler.
I mean, so most optometrists or ophthalmologists, even with a standard refraction, will do some test of the pressure in your eyes to see if you have glaucoma, because glaucoma can be a disease that results in loss of vision. So they may well have done a pressure of your eye to see if you had high pressure. And if you did, they may have actually picked up glaucoma as a part of the routine eye exam where you went in just to be refracted. It's just a pretty standard part of the eye examination. So if they said you have glaucoma, I would follow up. Again, if you have any concern, get a second opinion, see an ophthalmologist, but you may need to be treated. It's usually treated fairly easily with eye drops.
Yeah, she pointed out that they didn't tell me that whenever I was there a year ago. So only tell.
Yeah, I mean, it could change, but I would also support if she has any questions, go to an ophthalmologist and have the test done. Find out one way or the other, but get confirmative testing because if you have glaucoma, it needs to be treated.
And she has the rights to her medical records and have those seen by another physician. Before I reached for fraud in this situation, I'd try and get a better handle on the facts of the case. And certainly the medical record is a pathway to understanding what went on a year ago. And then having some expert second opinion help dissect what that was.
All right, Doc, that's what I have. Back to you.
All right. Well, I don't have a lot more on COVID. Anybody have a topic they want to talk about, John?
Well, I just got really excited when I read the article this week that there's now an expert system app that can evaluate people's coughs, apparently. And is a fairly good, supposedly, at diagnosing COVID based on the way you cough. So the fact that there's an app for it now means that we're endemic. So we've reached that level where just do it at home, figure it out by yourself with the help of your favorite smartphone or tablet, and off you go. So that was a kind of a funny moment, I think, in all this. And another less funny moment, but sort of in the unintended consequence, was an article on how many complications have come from home testing. People having animals poisoned and children poisoned with some of the reagents. Unfortunately, people mistaking eye drops for some of the diluents that are used. So again, the idea that we can hand the American public millions and millions of tests and not have a few folks go off the rails and do some unexpected things with those test kits, I think it's a cautionary tale about how far and wide you can spread, potentially dangerous chemicals and test kits. So,
well, and I was also interested, and Dr. Bratzler may have comments on this, that Flowflex, which was a very common home test, and actually there was an article that listed the 10 best or whatever, and it was one of them, has now been withdrawn from the market. I don't have the details of exactly why. I don't know if it was due to false results or if there were other issues, but I had a lot of people talk to me about, well, are these home tests really any good? I mean, the article comes out that they've removed this one. I don't know. Dr. Bratzler, what's your opinion on all the home tests? And there's a whole array of them now.
Yeah, so the home tests principally are antigen tests that are done at
Right.
home. They're not as sensitive as the PCR tests that we do in healthcare to see if somebody's acutely infected. But you can make them work better if you first, anytime you're symptomatic, you're more likely to test positive. Second, if you do have symptoms and you test and you're negative, repeat the test. Because there are studies that have shown that if you serially, in other words, do the test several times, you can approach the sensitivity of a PCR test by doing these rapid tests. So we always tell people, if you do it once, it comes back negative, but you're coughing, have some cold-like symptoms or other things, repeat the test the next day or two. Omicron was very fast, so you could repeat it every day, but just repeat the test. And if it remains negative, you can be pretty comfortable that you don't have COVID-19.
Do you have any information why Flowflex was removed?
I don't.
I would just follow up Dr. Bratzler's comments with follow the directions. These tests are, that you have to attend and follow them correctly. You need somebody who can read the instructions. There's unfortunately illiteracy out there, so hopefully there's somebody who can guide a person through this. It's not to be you can't wing these tests. They have to be, if you can't boil an egg, you might want to think about having someone help you do a home screening for whether it's pregnancy or COVID or anything, because these tests they can give you a completely wrong answer, particularly if you don't follow the instructions.
Yeah.
So
well, I think we've covered certainly the most talked about topics, the most discussed in recent days. I think that the Omicron subvariant is going to be very interesting in the next month in this country. And as people travel, spring break occurred. If we're going to see an increase, I think it's going to be in the next 2 to 3 weeks. And then I think it's going to be very interesting what happens. I agree with Dr. Bratzler. I don't think we should go backwards with masks and restrictions and shutting the economy down. And I do think people need to get vaccinated. I think if we are proactive, getting vaccinated, getting our boosters, even if it does mean a fourth shot, I think this country is going to be fine and the people are going to be fine. And I look forward to the kids being able to get their first shots from 6 months up. So I think there's some exciting things in the near future.
So, Larry, I wanted to make one last comment. It's
Sure.
in relationship to one of the comments that's come in through Facebook, but I just want to highlight, that it happens all the time, but I see people trivialize this disease. I just want to point out that in 2020, COVID-19 became the third leading cause of death in the United States. In 2021, this past year, it was the second leading cause of death. Killed more people than cancer does. The only disease that killed more people was heart disease. So absolutely, we're going to recommend vaccines as much as possible, because when you look at all of the studies of vaccines, the one thing that they're very good at doing is keeping people out of the hospital, having complications, and from dying from the disease. Again, COVID-19 was the second leading cause of death in this nation. More than 1 million people now have died from COVID-19. People want to trivialize this disease. 60,000 people a year die from flu shot, from
Flu.
influenza, and we given flu shots for years. Please don't trivialize this disease. It's killed so many Americans.
Thank you. I think that's an important point. John?
Well, it's nowhere near as important as what was just said, but it occurred to me that for a long time we've had the challenge in medicine to cure the common cold. And we've now got antivirals that work against coronaviruses. So I was wondering if Dr. Bratzler had any insight that if we use some of these new therapeutics, could we cure the common cold, do you think?
I think there are a lot of people that are hoping so, that maybe we'll see fewer common colds. The other thing is, they're looking at universal vaccines that won't have to change because of different variants. And people are still looking for that target protein or that target antigen on the coronavirus that causes the common cold and COVID-19, that we could potentially get the universal coronavirus vaccine and not have colds anymore.
So we could say that we can cure the common cold, and wouldn't that be a silver lining to the last couple of years?
Yeah, it would be.
Well, I think with that, we're going to end tonight. Great last words, and I thank you both for all of your input. I think it was a very important night for discussion. Scott, turn it back to you.
Doctors, thanks very much for your time. Appreciate all the comments. By the way, Jana, who Don's question about glaucoma, let me throw this up on the screen. So it's a misdemeanor to refuse medical records to a patient. I think Jana would know what she's talking about. So anyway, so Don, just research this one, because there may be a reason they want to send you those records really fast if they knew that. All right, so good luck with that. Dr. Bratzler, Dr. Armitage, and Dr. Bookman, who reminded me we're not only entering our third year, it's basically our fourth year of doing these streams, and really appreciate it. And I got to tell you, Dr. Bratzler, he's got to go to work, so we got to get out of here. He's 24/7 with Dr. Bratzler. So anyway, have a great evening. We'll see you Saturday morning, 10 a.m. with our education special, talking aviation this week for Oakland Ed. We're going to have a great time. On behalf of all the doctors, I'm Scott Mitchell saying have a great evening, and we'll see you Saturday. Good night.
Good night.